Now, this is a situation that a lot of us are confronted with. This is a 2-year-old female. Her Galeazzi test is negative, and by the Galeazzi test, we look at the level of the knees. This is a test to diagnose dislocated hip. Her abduction is symmetrical. Again, a test to diagnose a dislocated hip. Now, looking at this examination, one would think there's nothing wrong with this child. But in fact, she has bilaterally dislocated hips, and this is a nightmare situation for any of us, both in primary care pediatrics as well as pediatric orthopedics. Let's start off with the anatomy of the hip joint. It's a synovial joint. It's a ball and socket joint. It comprises of the femoral head and the acetabular socket. In the developmental stage, the ball and socket have a reciprocal effect on each other's growth, meaning that if the ball and socket are in contact with each other, they will positively affect each other's growth and development. And that's very important in most of the pediatric conditions. A brief note about the anatomy. This is the acetabular socket has a tri-radiate cartilage, TRC. There's the capital physis, or the longitudinal growth plate, by which the femoral neck grows. And then you have the trochanteric growth plate, which influences the growth of the trochanter. Now, disturbance in any of the above can lead to angular deformities. And again, I'll repeat, the femoral head and the acetabulum have a reciprocal effect on each other's growth. Now, if the femoral neck stops growing and the trochanteric growth plate continues growing, we can land up with a situation called coxa vara, where we have a decreased neck shaft angle. In situations where the longitudinal growth plate continues growing and the trochanteric growth plate stops growing, we can land up with a situation that we call coxa valga, where there's an increased neck shaft angle. The neck shaft angle is 150 degrees at 3 weeks of age and decreases to 120 degrees at skeletal maturity. Another thing that we got to factor in is femoral version. So femoral version is basically the amount of twist in the axis of the femur. This is normal. Here is a situation where there's increased femoral neck anteversion. That means the rotational axis is more twisted, and actually that contributes to in-toeing gait that we see so often in our clinics. This is a slide on the biomechanics of the hip. The hip is a machine, and it has lever arms, and the length of these lever arms can influence various forces acting across the hip. What we need to remember is that abnormal mechanics and loss of congruency of the hip joint can lead to premature osteoarthrosis due to unevenly distributed stress and easy fatigability of musculature that moves hip joints due to abnormal mechanics. Physical examination. So when a child enters your office, the most important thing, in addition to getting a good history, is a good physical examination. In any orthopedic examination, it always follows the look, feel, move, and measure. Without going into too many details, what I would really like to emphasize on is that hip pain is usually in the groin. The child will point anteriorly and in front of his hip. While examining, loss of abduction and internal rotation is the most sensitive clinical finding in hip pathology. In this illustration here, the examiner is internally rotating that hip on the left side, right there. This is a normal pelvis radiograph in a skeletally mature individual, and usually after you have taken a history and done a physical examination, the next thing to do would be to get a AP pelvis radiograph. To understand what is abnormal, we need to understand what is normal. This is a normal pelvis radiograph in a skeletally mature individual. As this talk unfolds, I'll show you more radiographs of pediatric hips. Now, this is severe hip dysplasia in a skeletally mature individual, and what you can see here is uncovering of femoral heads bilaterally. These hips may last a lifetime. These hips will never last a lifetime. And here again, what I want to emphasize is uncovering of the femoral head leads to unevenly distributed stress. It's almost like having somebody with a stiletto walking on you. This leads to destruction of articular cartilage and arthritis. So regardless of pathology, any alteration in hip anatomy is a setup for early osteoarthritis. Now, this is a child who had Perthes disease, which is avascular necrosis of the femoral head. On the left-hand side, you can see a abnormal hip, which possesses an incongruous joint, a shortened femoral neck. The femoral head is aspherical, and there's a loss of the head-trochanter relationship. So if you draw a line from the tip of the trochanter, it should pass through the center of the femoral head. And the child's left hip has lost that relationship. This is a slipped capital femoral epiphysis that was pinned many years ago, and you can see that the femoral heads are abnormally shaped. The right hip worse than the left. This leads to impingement, destruction of the acetabular socket cartilage, and early osteoarthrosis. This is hip dysplasia that's bilateral. Septic arthritis of the hip is another common condition. Here, there's complete destruction of the capital physis in both these patients. So again, to repeat that regardless of pathology, any alteration in hip anatomy is a setup for early osteoarthritis. In many of these situations, we could possibly avoid getting to this point, and that might involve diagnosing certain hip conditions and beginning treatment sooner than later. Most hip problems are age-specific. Hip problems at birth, the two most common are developmental dysplasia of the hip, as previously called congenital hip dislocation, and proximal focal femoral deficiency. Again, this is very rare. In this condition, the proximal femur is ill-developed. So a few words about developmental dysplasia of the hip, one of the most commonest pediatric hip conditions that all of us deal with on an everyday basis. So what is developmental dysplasia of the hip? So it's a hip that might be provoked to subluxation. There's a partial contact between the femoral head and acetabulum. A hip that might be provoked to dislocation. There's absolutely no contact. A hip that may or may not be reduced from above, subluxation or dislocation. Remember, the dislocation is the worst form of dysplasia. So these are bilaterally subluxed hips where the femoral heads are in contact with the acetabulum, but they are extremely uncovered. Again, over time, there would be destruction of articular cartilage as a result of unevenly distributed forces on the femoral head. These are bilaterally dislocated hips. So these hips are completely out of the socket and high riding. You can see small pinpoint capital epiphysis. So how do we approach a child with DDH? So the most important risk factors, the 4 Fs, we call it: the firstborn, female, a family history of hip dysplasia, and breech pregnancy. The various tests that all of us are familiar with: Barlow's, Ortolani's, Galeazzi, and I will go over each of these tests. Limited hip abduction is another important finding in a child with a dislocated hip. So what is the Barlow's test and the Ortolani's test? A Barlow's test is in a hip that is located, and by adducting and pushing, you can actually dislocate the hip, but it will pop right back in once you let it go. This may be seen in some children, and in the presence of ligamentous laxity, that could be secondary to the maternal hormones that facilitate delivery. Ortolani's test, the hip is out, and one can pop it back in, and one feels the clunk of the femoral head going back into the socket. That's the Ortolani test. So, to recapitulate, in the Barlow's test, the hip is in, and the test is to determine whether the hip is dislocatable. Basically, one can pop it out, but it pops right back in. And the Ortolani's test, the hip is out. The test is the clunk of entry on abduction. And all Ortolani positive need to be treated. The reason being that the femoral head and socket have a reciprocal effect on each other's growth. So if the femoral head is not in contact with the socket, both of them will not develop appropriately. Now, in certain situations, the Ortolani test can be negative, which means that it is out and it will not relocate back inside. And usually it's in long-standing dislocations or in teratologic hip dislocations in syndromic situations. This is a Galeazzi test. So in this case, the right hip is dislocated, and you can see that the knees are at different levels. Limited abduction is another indication of a dislocated hip, and you can see that on the right side. The left hip is nicely abducted. The right hip has limited abduction. Now, beware of bilaterally dislocated hips, as abduction will be bilaterally symmetrical, and this is the case that I alluded to in the beginning of this talk, where she has symmetrical abduction, the Galeazzi is negative, but she has bilaterally dislocated hips. It's a trap that a lot of us can fall into. So abnormalities of the neonatal hip can be grouped into instability of the hip, dislocatability of the hip, a positive Galeazzi test, and diminished unilateral abduction. And sonographic abnormalities, so in all children less than 6 months of age, the imaging of choice is ultrasound. The reason being that the capital epiphysis will not be visible, and it doesn't give you a good assessment of the hip, as a result of which we do ultrasound for assessment. And in ultrasound, and I'll touch more on it as we go along, you can check stability, femoral head coverage, and the development of the acetabulum. So there's a lot of literature on ultrasound screening, but the conclusion is that ultrasound screening in reducing the prevalence of late DDH was at best marginal, despite a considerable increase in diagnostic and therapeutic efforts. Today, ultrasound screening is limited to patients who are high risk, those that have a strong family history, and are breech presentation. Barlow positive hips may be safely monitored for 2 weeks before determining the need of treatment without altering outcome at 1 year. Remember that Ortolani positive need to be treated right away. And to recapitulate, the Barlow and the Ortolani's test. In infants less than 6 weeks of age who present with clinical and sonographically stable hips but show sonographic dysplasia, acetabular morphology usually improves regardless of abduction brace treatment. We follow patients with serial ultrasounds to make sure that the parameters have normalized. So in infants less than 6 months of age, ultrasound is the modality of choice. An AP pelvis radiograph not recommended, as capital epiphysis is yet to appear. In ultrasound, we look at many indices, but the two most important are the percentage coverage of the femoral head. 50% is normal. And alpha angle. The alpha angle is the angle that's made by the slope of the acetubulum with a line that runs down the bony ilium. So here I have this is a situation where I have two sisters born 2 years apart. Both of them have a strong family history of hip dysplasia. This is sister A. She had cardiac problems that led to her hip dysplasia going undiagnosed for almost 12 weeks. She was then treated with a Pavlik harness. So here you can see a line drawn down the bony ilium bisects a very small portion of her femoral head. So there's a large percentage of the femoral head that is uncovered, while this is a normal hip for comparison. So this line drawn down passes through a significant portion of the femoral head. This is the acetabular slope, and this is how we measure the alpha angle. So if the acetabular slope measures less than 60 degrees, so this is normal, the greater the angle, the better the coverage. The lesser the angle, the worse the coverage. And this is just how to put a radiograph and an ultrasound together. So this is in a child who's obviously more than 6 months of age because a capital epiphysis has appeared. This is a line that passes through the triradiate cartilage, and this is the slope of the acetabulum. This angle is called the acetabular index. A normal acetabular index is 25 degrees at 6 months of age. If you flip the ultrasound over, this is the slope of the acetabulum, kind of analogous to this. This is the femoral head. A line drawn down the iliac, the bony part of the ilium, bisects half the femoral head, or what we call 50% coverage. This is just to kind of help you understand what an ultrasound looks like with respect to a radiograph. So this is the Pavlik harness. It's been around since 1944. It has an 85% success rate. Basically what it does is that it keeps the hips flexed and abducted, which is usually the best position for ball socket contact. And like I said before, the femoral head and the acetabular socket have a reciprocal effect on each other's growth, and as long as they're in contact, they're both going to develop well. It permits ultrasound monitoring, allows diapers to be changed without removal. It's inexpensive and easy to use. However, it can be only used in the first 6 months, cannot be used in a teratologic hip dislocation. So if the hip is not going to go back in, a Pavlik is not going to be useful. It can cause femoral nerve palsy by pinching the femoral nerve up here, and in very, very rare situations, it is known to lead to avascular necrosis, that is basically loss of supply of the femoral head. So this is the same patient. Now this is an X-ray at 2 years of age. Improved the Pavlik harness. You can see she's got well-developed acetabular sockets with a very normal acetabular index. So line connecting the two triradiate cartilages, and the angle that the acetabulum makes with that line is called the acetabular index. Should be less than 25 degrees at 6 months of age. This is Sister B, and this is an ultrasound at 4 weeks of age. You can see that she's got significant hip dysplasia bilaterally. Here the femoral head is partially covered, but way below 50% coverage. Here the femoral head is completely uncovered. And here again, the radiograph and the ultrasound when you try to put both together. So to summarize, in DDH, respect and diligently seek out risk factors, family history, and breech, in addition to firstborn and female. Treatment of dislocated hips in neonates should be initiated immediately. That's an ortolani positive test. The best management of hips that are ortolani and Barlow negative, but initially sonographically abnormal, remains obscure. Ultrasounds done at less than 4 weeks of age can show a lot of false positives. Do ultrasounds in infants after 4 to 6 weeks, and all those that were breached and have a family history. There is a role for an ultrasound to be done prior to 4 weeks of age or a few days after birth. Only if the ortolani is positive to document that there is a sublux or a dislocated hip, and to initiate a Pavlik harness and then monitor improvement in the harness. A very important thing to remember is that not all ultrasounds are created equal. A normal hip can be made to look abnormal, but an abnormal hip cannot be made to look normal. Ultrasounds have to be done by technicians and pediatric radiologists or healthcare personnel who are comfortable doing an ultrasound, or they can lead to a lot of anxiety. So what happens if the Pavlik harness fails? Now, this is a clinical situation. This is a 1-month-old female, strong family history. Ultrasound shows bilaterally severe hip dysplasia. She's failed Pavlik harness treatment. So she was put in a Pavlik harness at birth, and she was closely monitored using ultrasound. Her alpha angle and her percentage coverage did not improve, as a result of which she went on to the next step, and that involved doing an arthrogram of a hip, which is injecting dye into her hip joint under anesthesia. So here you can see that both heads are dislocated in this bilateral arthrogram. When placed in flexion and abduction, they are reduced. This is what a child would end up in, or what we call a hip spica. It extends basically from the nipples all the way down to the ankles, with holes cut out for the perineum and the belly. An MRI is usually done post-reduction. So this slide actually illustrates the importance of axial image to assess reduction. In an X-ray, one would never be able to tell whether this hip is located. Now, on the right side, you can see that, so this is the acetabular socket, this is the femoral head, and the femoral head is posteriorly dislocated. This femoral head is located. So she underwent a repeat procedure, and now you can see that the head is inside the socket. So in some parts of the world, they'll do a CT scan with limited cuts because of radiation, and now we do MRIs to make sure that the hip is located following application of a hip spica. The same child, 2 years old, an AP pelvis radiograph shows mild dysplasia, and she's being treated with observation. Nothing is being done at this point in time. This is another presentation. This is a 22-month-old female. Her mother brought her in because she was walking funny. A pelvic radiograph showed a dislocated right hip, small capital epiphysis, steep acetabulum compared to the contralateral side. And remember that a dislocation is the most severe form of dysplasia because the ball and socket are not in contact with each other and cannot positively influence each other's growth. So we ended up doing an open reduction and a femoral osteotomy. So sometimes the femur has to be cut to help the ball sit inside the socket. This is her after a year, and you can see the acetabulum is beginning to develop a little better, but she needs to be monitored closely, and she may need procedures in the future to improve her coverage and help optimal development of her right hip. So what happens if a patient gets a little older and continues to have dysplasia? And this is a 5-year-old male with a past history of a closed reduction of his hip. So here in his pelvic radiograph, you can see two things. One is that his acetabulum is still not well developed when you compare it to the contralateral side. He also has a flattened femoral head as a result of avascular necrosis or loss of blood supply when you compare it to the normal femoral head on the left side. So if left alone, there's a chance that he could possibly end up like this, where cartilage will get eroded over time, lead to osteoarthrosis, and warrant a total hip replacement. So what are the types of dysplasia? There's a directional and a dimensional. And I will show you X-rays, radiographs to illustrate what I mean by that. The treatment in these patients is either femoral or a pelvic osteotomy or both. And basically, osteotomy means cutting the bone and repositioning the femoral head and the acetabular socket. So here, this is a directional dysplasia. You can see that this socket on the right side is very normal, nicely covers the femoral head. On the left side, the acetabulum is sloping upwards. The acetabular index is not abnormal. Dimensional dysplasia, and this is an immature skeleton, so because you can see the triradial cartilage, you can see the capital physis. So here the socket is small. The femoral heads are really large and uncovered with no socket over them. So again, over a period of time, because of this uncovering, there could be destruction of cartilage due to uneven weight distribution over those femoral heads. So this is dysplasia in the mature skeleton. The growth plates are shut, there's no triradial cartilage, there's no capital physis. So these are various kinds of osteotomies that we do in immature skeletons. Basically, we cut the pelvis or the femur and turn it over the femoral head to improve coverage. This is an osteotomy devised by Robert Salter from Toronto. There's another osteotomy that we call the Degas osteotomy. Basically, we cut the pelvis using an osteotome and then lever it down so that it improves coverage and improves the acetabular index. This is an 8-year-old boy who came with bilateral hip discomfort and an awkward gait. You can see that he has bilaterally subluxed hips. So we ended up doing bilateral femoral osteotomies as well as acetabular osteotomy. This is bone graft that is placed to keep that osteotomy open. This is him after a year following pelvic and femoral osteotomies. The coverage of his femoral heads has dramatically improved. Better coverage and weight distribution in both joints. And sometimes we'll be confronted with hip dysplasia in a mature skeleton where there are closed growth plates. In this situation, we do what's called a periacetabular osteotomy, where we carve out the whole socket and reposition it better and improve the coverage and weight distribution in the hip joint, and then fix it with screws. And sometimes we'll be confronted with a situation where the hip joint has already undergone some degree of wear and tear. This is a 19-year-old girl from Iraq. She's undergone a femoral procedure. In the past, a lot of pain in her hip joint, decreased joint space when you compare it to the contralateral side. This is a labrum that was ossified and broke off, hence producing this radiographic picture. Basically, she used to live in a world of hurt. So what we did for her was what's called a carry or a shelf procedure, which basically involves cutting the socket and pushing it inside. Again, the whole idea is to improve coverage, and we augmented it with a shelf, improve coverage and redistribute stress over a larger area, And then when salvage is no longer possible in an older patient, what we end up doing is a total hip replacement where you replace the acetabular component as well as the femoral head. These procedures are not desirable in a younger patient, as a hip joint replacement has a finite life. And sometimes in young patients, when hip salvage is no longer possible, we end up doing what's called a hip joint fusion. We actually ablate the joint and then fuse it. The whole idea is to remove the pain component. They are quite functional following this procedure. Of course, their lives are never going to be normal again, but they have no pain. Later on in life, this procedure could be converted into a total hip replacement. So to summarize, in a setting of developmental dysplasia of the hip, intervene as soon as possible after birth. By intervene, I mean get them on your or someone else's radar, refer them to a specialist. Remember that the femoral head and acetabulum have a reciprocal effect on each other's growth. Dysplasia could be directional or dimensional. The intensity and magnitude of the intervention increases with the passage of time, from simple observation to a Pavlik harness, to close reduction, spica, to osteotomies of the femur and the pelvis. The goal of these osteotomies is to increase area of surface contact between joint surfaces and evenly distribute pressures to prevent cartilage erosion. There are multiple procedures to manage this, to manage hip dysplasia. Then there are salvage procedures, and then there's total joint replacement. So as I mentioned at the beginning of my talk, hip problems are very specific to age, and now I'll touch upon problems that exist in patients who are toddlers to approximately 8 years of age. The most common clinical presentation in a child with a hip problem is they walk into your office with a limp. Now, it could be any of these: transient synovitis, Perthes disease, an infection, trauma, a tumor. It could be inflammatory arthritis. It could be Lyme, if you're in New England, and it could be developmental dysplasia of the hip that went unrecognized. Inability to walk is usually, it could be any of the above, but we got to keep septic arthritis in mind. And then hip problems in 10 to 14 years of age. Again, a lot of the ones that I mentioned before, I like to add slipped capital femoral epiphysis to that group. And inability to walk, again, septic arthritis, and an acute unstable slipped capital femoral epiphysis. So a few words about transient synovitis. It's the most common cause of hip pain in childhood. The true etiology remains unknown. It's usually a monoarticular hip pain and is restricted internal rotation and abduction. There's complete resolution in a few weeks. There's no diagnostic test, and the differential diagnosis usually includes septic arthritis and Lyme. The only test that's positive would be joint fluid on ultrasound of the hip in most cases. Let's go on to Legg-Calvé-Perthes disease, described in 1910. Basically, it's disruption of the blood supply to the femoral head. It's a self-limiting disease, which basically means that the disease process dies out on its own. The interesting thing about this disease is that despite 100 years of research, we still don't know the etiology, as a result of which treatment modalities are controversial. It's most common in boys, Caucasians, can be seen from 2 to 14 years of age. 15% can be bilateral, and a significantly increased risk with parental smoking and a low socioeconomic status. Disruption of the blood supply to the femoral head is a key pathogenic event. And the infarcted femoral head begins to deform when forces applied to femoral head are stronger than its ability to resist deformation. Remember that the deformed femoral head serves as a template for a future hip joint. So if you have an abnormally shaped femoral head or an incongruent hip joint, that's going to lead to osteoarthritis. in early adulthood. An example, a 5-year-old girl, she presented with right hip pain. And actually, I treated her as a case of transient synovitis for a few weeks before her radiographs began to show changes. It's one of the changes that we see in the radiographs. You can see increased density of the capital epiphysis, and then flattening on the right side. The contralateral hip is normal. So what are the aims of treatment? The long-term aim of treatment is to prevent the onset of secondary degenerative arthritis of the hip. And one of the most important things in managing Perthes disease is maintaining sphericity of the femoral head. So what are the different ways that the proximal femur shape can get affected? So by the actual process of infarction and bone softening and resorption, by destruction of the adjacent physis, by extrusion of the femoral head. So what happens in many instances is the femoral head begins to extrude or move out of the socket for reasons that we do not understand. So this is a picture of extrusion, and you can see that the femoral head starts moving out of the socket. It's already infarcted, it's softened, and now weight-bearing stresses is going to flatten it even more. So the short-term aim is to prevent the femoral head from getting deformed during the active stage of the disease. And in patients in whom deformation has occurred, then one wants to minimize the adverse effects of these alterations in the shape of the proximal femur. So one of the key principles of treating Perthes disease is the principle of containment, where we utilize the acetabular socket to mold the femoral head. It can either be done with conservative measures using physical therapy or abduction bracing, as in this instance, it's very inconvenient for the child. And then, by cutting the bone, the femur or the pelvis, and improving coverage. There are a lot of things that are controversial about Perthes disease, but what are the things that we know? It's a disease that burns itself out. In the process of going through the disease, the hip joint shape gets altered, and this affects the biomechanics and also sets up a template for early adult osteoarthritis. Radiographs are still the imaging modality of choice to diagnose and plan treatment, though an MRI will help you make a much earlier diagnosis. Younger children have a relatively better prognosis as the pestle of the femoral head has remodeling potential. Containment is the mainstay of treatment and can be done by either surgery, skilled physical therapy, abduction bracing, and timing of surgery is critical to success of containment. If the head is hardening with the advancement of skeletal maturity, it is not going to mold, and hence older children do worse. Another clinical example, she's almost 5 years old. This is a stage of fragmentation, and then reossification and healed Perthes. And like I mentioned at the beginning of my talk, regardless of pathology, whether it's infective, whether it's Perthes, whether it's hip dysplasia, any alteration in hip anatomy is a setup for early osteoarthritis. Let's move on to the slipped capital femoral epiphysis, another very common condition to afflict the pediatric hip. It's a displacement of the femoral head relative to the femoral neck, and it occurs through the growth plate of the femur, more common in either very obese or tall, thin individuals. So when children who have this particular habitus enter your office limping or with hip pain, and they're within this age group of 9 to 16, be very aware of this particular diagnosis. So here you can see the femoral, it is sheared at the growth plate and slipped posteriorly. It can be as blatant as this, or it can be as subtle as this. When you look at both hips here, you can see on the normal side, there's a very thin line. Here you can see the physis is blurred, and this patient had a slipped capital femoral epiphysis. If they have endocrine disorders or they're undergoing radiation or chemotherapy, there are high chances to have a slip. And there are two types. There's an unstable which actually behaves like a fracture. And there is a stable. So stable are more tricky to diagnose. They'll walk into your office, they can weight bear, they sometimes talk about pain in the knee. Many times they get diagnosed as a groin pull. It's very important to pick these stable up because a stable can slip acutely without warning and convert a stable to an unstable situation. So clinical assessment, the child walks in with a limp. The foot is usually an external rotation, and external rotation gets worse when the hip is flexed. A radiological assessment, you get an AP pelvis film and a frog lateral. It's critical to get a frog lateral. If the AP and frog lateral are normal, but you're still suspecting a slipped capital femoral epiphysis, then an MRI of the hip would diagnose a condition called a pre-slip, where it's threatening to slip, but it hasn't. So here this is a frog lateral, and you can see the widening of the physis when you compare to the other. Here the capital physis is a thin line, while here it is widened. So common pitfalls at the primary care level: not obtaining pelvis films and only knee films instead. So we do encounter situations where children walk in with multiple radiographs of the knee and actually end up having a slipped capital femoral epiphysis. Misreading radiographs, so if it's a very subtle slip, one may not pick it up, and then failing to make a timely referral. So downside of not making a timely referral is that stable slips can slip further over time, worsening deformity, or turn into unstable slips that behave like acute fractures. So the worse the deformity, the higher the likelihood of developing early osteoarthrosis and producing what we call impingement or through a CAM lesion, and this is a CAM machine. So this is a patient who had bilaterally slipped capital femoral epiphysis, and again, this can be bilateral in almost 30% of the cases, so it's critical to closely watch patients if they've had a unilateral slip. In this situation, note the abnormally shaped femoral heads that will impinge and wear down the acetibular socket, leading to osteoarthritis. So what's the role of a primary care pediatrician? Early diagnosis and referral, prevent further worsening of deformity and turning a stable to an unstable situation. The goal of a pediatric orthopedist is to prevent further slip, and for that we pin the slip. We try and avoid complications like avascular necrosis and chondrolysis. We maintain an adequate range of motion and try and decrease the risk of early osteoarthritis. So this is what we do. We'll pin the hips to prevent further slip. And over time, there'll be closure of the growth plate. So many of these patients can land up with a leg length discrepancy because this growth plate does not contribute to growth anymore once it's been pinned. And to repeat, early diagnosis, AP and frog lateral, when a child presents with knee or hip pain. If it's an unstable or even in a stable situation, put the child on crutches, toe touch, weight bearing in a stable slip, a wheelchair or a stretcher in an unstable slip, it actually behaves like a fracture. Refer as soon as possible. Don't send for physical therapy when in doubt. You can make a bad situation worse. Clinical example, this is an 11-year-old Amish boy. Actually, he's very tall and skinny. He has a history of pain in his left groin and knee for 2 months, and a little on the right side too. Presented with sudden worsening of symptoms, so most probably what he had was a stable that turned into an unstable slip. And this is what I ended up doing for him. He did have pain on the right side, which was one of the reasons that I pinned him. He was also, he lived far away in Maine, and I wasn't very sure about his social situation, so I ended up doing what I would call prophylactic pinning on the contralateral side. Septic arthritis. So how does the patient present? Fever, inability to bear weight, in a young child or a neonate is usually what is referred to as pseudoparalysis, or inability to move the extremity. The child will keep the hip flexed, abducted, and externally rotated. And again, to repeat, the most consistent finding is loss of spontaneous movement of extremity and posturing of the joint at rest. So if one has a strong clinical suspicion of septic arthritis, especially in a neonate, it's critical to distract the neonate either by initiating breastfeeding and then try to move the hip, try to internally rotate and abduct very gently, and the child stops feeding or starts crying, and do this on multiple occasions, one should strongly suspect septic arthritis. Again, this is the normal pediatric hip, and I'm showing this again because what happens is an infection of this area will destroy this joint, destroy this growth plate. So how does it get destroyed? There are proteolytic enzymes released from synovial cells. There's elevation of intracapsular pressure leading to necrosis of the femoral head. Destruction of articular cartilage usually begins pretty rapidly, and this is a surgical emergency. So in an infant, destruction of the capital physis and epiphysis can result in partial or total destruction of the femoral head and neck. These are classifications, and all that they basically show is the amount of destruction of the proximal femur and acetabulum following septic arthritis. So it is a surgical emergency. It needs to be diagnosed as soon as possible and needs to be treated, and usually the treatment would be an arthrotomy of the hip joint. Consequences of untimely treatment are these two radiographs where there's complete destruction of the proximal femur. What other problems do these children have? They have instability due to damage to joint components. They end up with a deformity, shortening because of damage to growth plates in the area, altered mobility, stiffness, and pain. So on acute presentation, ultrasound will confirm the presence of an effusion. And again, it's hard to say whether that effusion is pus or not unless one aspirates it. MRI would help detect osteomyelitis of the proximal femur if present. The other differential is transient synovitis. Absence of signal intensity in the surrounding soft tissue and bone would point towards transient synovitis. We're all familiar with the Coker criteria to differentiate septic arthritis from transient synovitis. It's usually useful in a walking child, but again, having a high clinical suspicion is the most important, is paramount in diagnosing septic arthritis. Another differential is localized cellulitis. Joint range of motion is maintained in cellulitis. The ultrasound may not show any effusion. So treatment of septic arthritis is surgical drainage and irrigation of joint. If surgery is not followed by rapid reversal of symptoms and signs, re-exploration should be considered. Sometimes we put the child in a hip spica to prevent pathological dislocation because the large effusion could have stretched and destroyed the capsule. Antibiotic regimen to be started only after aspiration, and now there's a recent trend in decreasing parenteral antibiotic treatment, especially if constitutional signs improve and there's no osteomyelitis. The role of the primary care physician is to have a high level of suspicion, make a careful clinical assessment, and like I mentioned before, in the neonate, distract the neonate with breastfeeding or some toys, and very carefully assess, especially internal rotation and internal rotation of the hip, and see if it produces discomfort or pain. Confirm presence of an effusion with an ultrasound, which is most of the times accompanied by aspiration of the contents which are then sent for analysis of the synovial fluid. Always think of concomitant osteomyelitis, and then think of Lyme disease or equivalents depending on certain geographic locations. So I've covered most of the common conditions in the pediatric hip that, as a primary care pediatrician, one would encounter either in the office, on the floor, or in the emergency room. I'd like to summarize my talk. So, in summary, a physical examination, in addition to a history, is key to further evaluation. So, look, feel, move, measure. Remember that hip pain is usually in the groin, and the patient will point in the front. Sometimes it can be referred to the knee. Loss of abduction and internal rotation is the most sensitive clinical finding. Imaging is extremely important. Any alteration of shape of individual components of the hip joint leads to incongruency of the joint and can predispose to early osteoarthritis. Hip issues are very age-specific. So hip issues at birth, the two most common are developmental dysplasia of hip and proximal focal femoral deficiency. In the toddler to 8 years of age, there are conditions that extend from transient synovitis, Perthes disease, inflammatory arthritis, previously undiagnosed hip dysplasia. If the child is unable to walk and has fever, think about septic arthritis. 10 to 14 years of age, think of all the other conditions I mentioned before, and in addition, think strongly about slipped capital femoral epiphysis. There's nothing such as a groin pull in that child. There's nothing such as a groin pull in that age group. Have a strong clinical suspicion for slipped capital femoral epiphysis. When coming to developmental dysplasia of the hip, respect and diligently seek out risk factors that include family history and breech presentation. Ortolani positive should be treated immediately with a Pavlik harness. Ultrasounds done at less than 4 weeks of age can show a lot of false positives. However, if one has a clear-cut ortholani positive, one could do a hip dysplasia one could do an ultrasound to document a dislocated or a subluxed hip. Do ultrasounds in infants after 4 to 6 weeks in all those that were breech and have a family history. Remember that not all ultrasounds are created equal. A normal hip can be made to look abnormal, but an abnormal hip cannot be made to look normal. The femoral head and acetabulum have a reciprocal effect on each other's growth. The intensity and magnitude of the intervention increases with the passage of time, from simple observation to a Pavlik harness to spica to osteotomies. The goal of anything that we do is to increase the area of surface contact between joint surfaces and evenly distribute pressures to prevent cartilage erosion in the long term. There are multiple procedures, then there are salvage procedures, and then the end point is total joint replacement. As far as Perthes disease is concerned, it's a disease that burns itself out over a period of time, but in the process, the hip joint shape gets altered, and this can act as a template for early adult osteoarthritis. All treatment is directed at maintaining sphericity of the femoral head and congruency of the hip joint. When it comes to slipped capital femoral epiphysis, the role of the primary care physician is to make an early diagnosis, a pelvis x-ray, AP and frogolateral for knee or hip pain when suspicion. Do not permit weight bearing once you've made the diagnosis, either toe touch or put the patient in a wheelchair or stretcher in an unstable situation, and refer immediately. Don't send for physical therapy when in doubt. It can make a bad situation worse. Septic arthritis can affect multiple joints, and my talk was more specific to the hip. The role of the primary care physician is to have a high level of suspicion, do a careful clinical assessment. Remember that a septic arthritis of the knee or elbow or the ankle is very easily diagnosed because one can visually make a good assessment, but in the hip, it's hard to make a diagnosis by just observation. Confirm presence of the effusion with ultrasound. Think of concomitant osteomyelitis. Send labs. Avoid antibiotics till after aspiration. Think of Lyme disease equivalents depending on certain geographic locations.